Good evening, viewers. Welcome to another episode of Speakers Gallery. Our guests today are three eminent professionals. To my immediate right is Dr. Peter Kibet Shikuku. Dr. Peter Kibet Shikuku is a hematologist and an expert in blood transfusion. He's a lecturer at the University of Nairobi. Welcome, Dr.
Thank you. Thank you much.
Next to him is Dr. Jared Omogi, who is an epidemiologist. He's also a statistician, he's a consultant, and with a wide knowledge in areas of medical biochemistry and the rest. Welcome, Dr. Omogi. And the last but not the least is Dr. Amaya Amuko.
Yes.
He is the medical superintendent for Bliss Healthcare. It's a private entity. He's also the leader of the response team, the COVID-19 response team of Bliss Healthcare. Welcome, Dr. Amaya Amuko.
Thank you very much.
I'll start with you, Dr. Kibet. I'll also add, as part of the introduction, that you're also the team leader for COVID-19 response team, Corona response team of Nairobi West Hospital.
That's true.
Daktari, what is this virus? What is COVID-19?
Yeah, so COVID-19 is one of the corona viruses that belong to a bigger family of viruses we call coronaviridea. And basically within this family are two key types of viruses. The first is called the coronavirus, where we shall be discussing a little more on the various strains. Then the next is called the toroviruses. The toroviruses, yes, toro.
Yes.
The toroviruses are known to cause what we call enteric fever in animals. So we will not bother ourselves with the toroviruses. We will focus more on the coronavirus. So the coronaviruses have 7 different strains. Mm-hmm. And out of those 7 strains, I'll possibly focus on 3 that have some human element in terms of causing disease.
Yes.
The first is called MERS, M-E-R-S, which was a Middle East respiratory syndrome virus.
Which I'm made to believe came from the camels.
Yes, and again, that is something that occurred some times back. Mm-hmm. The second strain was called SARS-CoV, which is a severe acute respiratory syndrome virus. Again, that also came and has devastated people quite a bit. Yeah. And then now we have the novel type that is in existence, which is frustrating the entire world as a pandemic, which is SARS-CoV-2. WHO decided to make it easier for all of us and renamed it COVID-19 because this virus seems to have started some time back last year in 2019. Yes. In Wuhan, and we all know the story behind Wuhan. Now it is here with us. So basically, this is a virus that is of interest to all of us. And being a virus, the effects can be a little frustrating. Yeah. And I guess that is why the medical fraternity is attempting to figure out a solution to it. Yeah.
Explain to us on the exposure, the progression. How does one
so the virus
catch that virus? Is it because we also hear information these days that it could even be airborne?
Yeah.
But how do you contract it? How do you pick it from one person to the other person?
Yeah, so the virus has actually 2 major modes of transmission.
Yes.
The key mode is person-to-person transmission. And I guess this is the reason why the government is putting a lot of emphasis on, people, keeping
social
some distances
yes,
between themselves. And we all know that social distancing is now going to be an issue. I want to trust that it might even be a criminal offense, to interact unnecessarily. Because the virus will then be passed from one person to another. And the reason why social distancing is recommended is because the virus happens to be transmitted through droplets. So if you get exposed to droplets that come from an infected person, then those droplets can gain entry into your system through the mucous membranes. So if you look at the sizes of the droplets, there are three major, let me say from a layman's language, three different sizes of the droplets. We have the huge droplets that when they come out of the infected person will drop closer to that person. Then you have the next moderate sized droplets that would fall a little further. And the smaller sized droplets would move further, about 6 feet away from the person.
That is through coughing.
This is through
sneezing.
coughing, sneezing, you know, spitting. All these kind of behaviors can then move the virus from the infected person to whoever is closer to you. So the safer distance that we all should be working towards is almost 2 meters away, because the farthest the virus can actually drop is about 6 feet. So that is a major mode of transmission. But then the other mode is through, you know, surfaces. If the virus falls on a surface, you know, on your hands, you greet somebody else, and then you are able to transmit the virus from yourself or through these contacts to your mucous membranes again. And, you know, the mucous membranes are generally around the mouth, the eyes, and that is why people always tell you, please stop touching your eyes, please stop touching your face. You know, you don't want to start contaminating yourself. Again, it is on that basis that
even if that droplets that came into touch with your own body is dried up within the system, does it still become?
So again,
let's assume, for argument's sake, you had a discussion with somebody, and 3 hours or 4 hours later on, when you know it's dry but you have not washed your hands, you rub your eyes. Are you likely?
Yes, you are likely to you know, to contaminate yourself, and you can get the virus.
So it can leave also on a dry.
Exactly. So even if I mean, if you came into contact with the droplets and you don't happen to decontaminate yourself or clean your hands. When you use the sanitizers that are commonly used, one thing that has been tried is that the virus dies within a minute on exposure to these sanitizers, especially if you get sanitizers that are well prepared, because the biggest worry is when you start getting sanitizers with lower concentrations of alcohol or whatever disinfectant is being used. So appropriate ratios need to be maintained. The second thing is you could also wash it away, and that is why with soap and water and good cleaning, you should actually be able to remove the virus. And we recommend, for the sake of not just finances, even for sustainability, that we try to clean our hands as much as possible, maintain and avoid touch as often as possible, so that then you protect yourself, you protect those around you. Now, the issue of the airborne transmission is a rule that we encourage clinicians managing patients to apply, but it does not mean that the virus is transmitted through the airborne. You can actually aerosolize the particles. Let's assume you have these particles with an air conditioner in a room. You can transform what was supposed to be falling into, circulation in the air.
Yes.
Exactly. So again, so basically in the medical world, we encourage clinicians to practice airborne precautions. And I think that is where now people are misunderstanding the issue about the airborne as a disease. And, if this was the case, most of us would be affected by now. So we encourage clinicians to literally practice airborne precautions, because you just don't know what might be in the air, and you have to be protected from any infections because of the nature of work that we do. Yeah.
Dr. Omogi, you're an epidemiologist.
Yes.
We constantly come into terms with the words like isolation, quarantine, safe distance, as you put it right now, or social distance. What are these exactly?
Yeah. First of all, thank you for having me in the show.
Yes.
Let me start with quarantine. Quarantine means that you put aside persons that might have been exposed or might have come into contact with a person that is suffering, or might have visited an area with people that have already been affected. So, in quarantine, the people in quarantine are not sick. What they are doing is they are put somewhere and they are being checked for the incubation period. Again, incubation period just basically means the period between exposure and beginning of the symptoms. And for COVID-19 is about 2 to 14 days. So in quarantine, they're not sick. But in isolation, these people are already confirmed sick. They're already confirmed that indeed they have COVID-19. So they are isolated. And of course, there are rules when coming to isolation compared to quarantine. One, in isolation, you make sure that one, even the utensils that the person is using are totally different, meaning there are no sharing of utensils, no sharing of beds, and if possible, there should be sharing of even a room. But because of our infrastructure, you may find that in isolation rooms here in Kenya, we may be sharing the room, but again, there's that distance that is allowed.
Which you call the social distance.
Yes, that's allowed.
Which, if, as the Daktari puts it,
Yeah.
we have, if you have an air conditioner or something like that, the possibility of those that circulating within the air itself and
it's quite
ending up reinfecting again.
Yes, so that's why Daktari was saying most of the clinicians have then to take care of that. So in quarantine,
Take care of themselves too.
Take care of themselves too, because if you remember, or if from what you've read, is that about 20 to 30% of deaths due to COVID-19 are health workers.
Yes.
So they're not immune to not getting. They're not immune to COVID-19.
Yes.
So when coming to quarantine,
Yes.
again, there is again protection of the same people that are quarantined, because you may find, yes, they might have been exposed, but they may not get. But again, we have those we call asymptomatic.
Yes.
That means these people might be having the virus, but it's very low. The infection to the other people or passing to the other person is quite low. That's what research have shown, or what we've read so far. But we ought not to forget that COVID-19, the current knowledge that we have about COVID-19 are from SARS and the MERS. So and that's why it's called a novel coronavirus. Novel meaning because it is new. That's why it's called a novel. So
Hybrid like.
It's new.
Okay.
That's why it's called a novel coronavirus. It's a new virus. So going forward, the quarantine and the isolation, but then there's what we call contacts. When do we say someone has come to contact, or how do we then deal with these contacts? First of all, who are contacts? Now, contacts are persons who might have interacted with person tested positive for some time. This can be a health worker in the ward. This can be just a normal patient who went to the hospital and were sharing a seat while maybe waiting for a clinician. 3, this might have been a person, or might be people who are so close to the contact for some time in an area. So these are what we call...
Like a family.
Like a family. These are what we call the contacts. But then you've had what is called the contact tracing. That basically means going retrospectively.
Backwards. Everybody have had a contact with.
Everyone that had contact.
Everybody the contact has had a contact with, or contact has had a contact.
True.
You continue progressively.
Yes, you continue progressively, which it's a huge task to follow one by one till you find. Remember, like in Wuhan, for example, they went until they found about 7,000 persons. And you'd understand, because of the infrastructure, because of how even they're set up. But within us, getting that contact tracing is not a very easy thing. If you had today, we are told, for example, now 4 counties are the high-risk areas, that is Nairobi, Mombasa, Kilifi, and Kwale. So by the time they come to that, it basically means that high chances, most of the contact tracing or the persons that have been followed retrospective or backward mostly come from these areas. But again now, there's a case that has been reported from Siaya County, where I come from. So that again tells you that then there will be need of much use of resources to look for these people within these, so far now, 5 counties that we've been told about. Yeah. And maybe statistically, we began with 2, remember? Then we went to 4. Then we went to
And we are
7.
now at 16 or 17?
Then we went to 7.
5.
Yeah?
25.
Today?
Yep.
Yeah, so we began with 2. Then we went to 4.
Oh my God.
Then we went to 7. Then we went to 15. Then we went to 16. Then now we are 25. So that tells you how the infection is going on, and there is much need, as Dr. said, that we need to keep in mind, 1, hand hygiene, 2, respiratory hygiene. That is, as you sneeze or cough, maybe you have to bend your elbow so that you do that. And if you suspect that you might be having COVID-19, if you suspect, then stop using a handkerchief. Then use a tissue. Immediately then, you have to dispose it, maybe flush or to a dustbin that is not touched. Yeah.
Oh my God. You're a statistician also. And basically are able to, within the frameworks of the modes you use in reaching at, in statistics, in finding out how the prevalence can go, given one environment. If you look at the number of cases that we have right now, if you had to give not a prediction as such, but pretty much as close as possible to a scientific configuration, how bad is it? How bad are we off today? And you know, you're not an alarmist. You just use your pure scientific, what you call, skills and what you've learned, and tell us that how badly off are we?
From the way it
because I just to emphasize further,
yeah.
You're talking about the deputy governor of Kilifi,
Yeah.
who's supposed to have had contact with 363
Yeah.
or 62 people. So if we were to assume 50% of the 25 we have today have probably had a similar contacts,
Yeah.
then what are you looking at?
Okay, one thing that we ought to understand, if you compare COVID-19 and SARS,
Yes.
that is severe
Yes.
Respiratory syndrome,
Yes,
the COVID-19 infection rate is much higher
yes,
than the SARS,
yes. And the mass.
than the SARS
Yes.
and even MERS.
Yes,
But the good news is that the mortality rate for SARS was much higher compared to COVID-19. But in terms of the infection, so far, we've got so many cases, not even the deputy governor of Kilifi. If you go to Siaya, we have the father, Father Duor. If you go to Kakamega, we have MCAs
who have tested positive.
who have tested positive and who came from overseas. They came to the country. They've been mingling with the people, and they had to be forced to go to quarantine. If you go to Coast, for example, there are cases of the same. So that tells you that the infection rate going forward, statistically, not being an alarmist, we might expect much higher infections.
Thousands upon thousands.
Not thousands, maybe not thousands for now, but should we?
If somebody has had contact, only one person has had contact. Okay, he's a politician, a famous politician who basically has more contacts than the ordinary person. But let's assume if in that period of time he's had with 362 people, even if each one of those 362 people has had contact with only 20 people or 30 people, you multiply that with that.
Yeah, but
You're then talking about 10,000 and above.
yeah, but remember, as much as the infection is so high, it doesn't mean that should you come into contact with the person, then you will automatically get the
So
get
what
the
is the
COVID-19.
percentage of infection of those people who came into contact with, as far as, okay, the age differences, age varies.
Yeah.
The more vulnerable are the people with pre-existing conditions, the elderly. I mean, those are the ones who are more vulnerable.
Not really vulnerable. Again, what we ought to remember is that COVID-19 affects all the ages. not only those that have got other diseases, no. It affects all the ages, from young to the old. But when it now comes to vulnerability, basically means that should you have another disease, what we call
Pre-existing
comorbidity
condition,
or
yes.
pre-existing conditions, then you are high likely
More
for the
susceptible.
COVID-19 to go with you to be severe, unlike other ages. But we ought not to forget that in China, there was a case of a child, a baby who died of COVID-19. So it is not about the age. The ages is, everyone is much affected. But if I come back to your question,
And there's a lady who was 103 years old.
yes,
Who
and
basically,
who
pulled
came
through.
out, who came
Pulled
out
through,
of it,
yes.
yes. So, but to come to your question, the infection rate again is very high. That we must, and should, because those are the only cases that known, the ones that came but did not go to self-quarantine. Those are the only cases that we know, but we may be having more of such. So the truth is, as the CS said, 2 weeks, given the 14 days, it's quite critical. And by the end of this week, if you looked at the trend in China, not in China, but in Italy, it began this way. Within the 3 weeks, they are talking of thousands. But let's not forget, when COVID-19 was first reported on 31st December 2019, within 67 days, we were 100,000 cases. After 67 days, within 11 days, that is 78th day, we were 200 cases. Add 4 days, that is 82 days, we were 300 cases. 300,000, sorry. So 67, there were 100,000. Plus 11 days, there were 200,000 cases. 82 plus 4 days, we were talking of 300,000 cases. That's how infectious rate is high when coming to COVID-19.
So what are we looking at?
We must...
God forbid, but we are looking straight in the eyes of a possible disaster.
Should we follow what Dr. is saying?
Yes.
We'll come out of it. But if we are not, we are looking for a disaster up here.
Actually, scientifically speaking, just to add on top of what my colleague has mentioned, so there's a formula you can actually use for projection.
Yes, that's what I thought. Yes.
And again, the epidemiologists would know this better than me.
Yes.
They call it the RO,
Yes.
which is basically the number of people one person
Is
could
able to infect.
potentially,
Yes.
pass the disease.
And you multiply with the
Yes,
number you have.
and you actually use that figure.
Which have not been isolated.
So
yes.
if you look at COVID-19,
Quarantine, yeah.
the range starts from 3.3 to about 5.5. We are as good as saying one person can infect 3 other people.
Yes.
And those 3 would infect. So basically, if we started with one person, the next is 3, the next is 9, the next is 27. Basically, that is how the disease will be factored out. If you're using 1 to 5, basically you're starting with the first 5.
And all that can
then
happen.
the next 25,
Yes.
the next 225, 125. So that's how it gets factored out. So if you have one person who was in contact with, 200 plus, then you're dealing with thousands of people.
Dr. Ari, you are in the response team, of, you're leader of the response team for Bliss Healthcare. What exactly are you doing?
No.
Are you just sitting back there waiting for these things to come to you, and then you begin wondering what to do with it, or you already have a strategy in place?
Yes, thank you.
Prevention and the rest.
We have a strategy. Now, one thing we have been having is that...
Dr. Ari, if you just hold on to your thoughts briefly.
Okay.
Viewers, we are going to have a short commercial break and shall be right back. Welcome back to Speakers Gallery. For those of you who are joining us now, our guests today are 3 health sector professionals. We have Dr. Kibet Shikuku, who is a lecturer in the University of Nairobi in hematology and blood transfusion. We have Dr. Jared Omogi, who is an epidemiologist and a statistician. He's a private consultant. And we have Dr. Amaya Amuko, who is a medical superintendent in Bliss Healthcare. Dr. Maya,
Yes.
you were just telling us when we went for the short commercial break on what exactly are you doing right now as the COVID-19 team leader in your own private entity.
Thank you, sir. Now, I work for Bliss as a private institution and also as a primary healthcare service provider, meaning we are the first contact with patients on the ground. So with the advent of the outbreak, most private entities have had to actually tighten up their resources, and we have increased what we call our infection prevention and control measures, which include the things we have been seeing around, like hand washing, hand sanitizing, right? As my fellow learned colleagues have said, we have a very, very glim picture of if the 10,000 people flock one hospital, if they end up flocking, the clinics in the country, we'll have a health crisis on our hands. And that is why they are really insisting prevention is better than cure. But at this point, we don't have a cure. So prevention is everything we have, right? So how do we prevent this from happening, right? The measures you've just had, people have to do self-quarantine for at least 14 days when you've traveled. You need to call the disease surveillance, office. You're being told at JKIA, when you go home, kindly self-quarantine. Do not leave your house. Don't go for parties and disco matangas and everything. Just stay in your house for 14 days. If you develop the symptoms, which we'll discuss in a few minutes, you know what to do. You will have a hotline. There are so many hotlines that have been released. There are so many facilities that are now decentralized to test, right? But what as normal Kenyans, kawaida Kenyans, what can we do to prevent this from spreading? So first things first, we've talked about hand washing, right? We need to start practicing hand washing and the correct procedure. We need 5 motions, at least 20 seconds. We need to get rid of the virus from our hands. And we need to do that frequently. Maybe as a legislator, you can tell us where we're having water shortages, the government may need to step up. Mm-hmm. We might have, people living, we know how Nairobi is, we have slums, we have areas where we've not seen water for months. So I don't know, we need to pull up our game. Even we know that some of our healthcare facilities will depend on this water. So we need to improve on hand washing. We need to improve, even as the government is giving free soap, we need water. Water has to be running water. I'm sure most of us are used when you go to Nyama Choma, you dip your hands there, but things have changed. We are not in a normal situation. Yeah. We have to have running water. Secondly, we have people who are at a higher risk of exposure, right? But right now, since it's a pandemic, it's been declared as WHO pandemic, we need to step up what we used to do.
What do you think, in your opinion, we should do? We should have had a lockdown from like yesterday or day before yesterday, or what do you think we should do?
First of all, every Kenyan listening to us right now needs to take it upon themselves and be responsible as a custodian of this country. If you are told, first of all, self-quarantine, kindly do it, right? The next thing you're being told is spacing out, social distancing, right? I think I saw a video of someone sneezing on someone, which was very rude, right? We need to start practicing, cough etiquette, sneezing etiquette. Let's stop spitting all over the place, right? Those measures will assist, and it has been shown to assist. And a case example, in Sierra Leone, they had a huge outbreak of Ebola, and it was being spread by poor sanitation. So what do? They practiced hand washing. All areas were put hand washing stands and stations with soap.
And clean toilets.
And clean toilets. So what did this do? It reduces the number of outbreaks of Ebola. Mm-hmm. But an unintended effect was that it also cleared an outbreak of cholera, which they didn't have to use money to control. Mm-hmm. So you see, hand washing is very important. Secondly, the hand sanitizers we are using should be employed in areas where we do not have running water. We need to also sanitize our hands, right? Now, particularly where you have frequent contact with people who might be at risk, like in the clinics, hand sanitizers are very welcome, right? Now, some of the problems you are going to face as a country, and you know, like right now there's been a lockdown on alcohol because part of the base of making the sanitizers is the alcohol. So the government is taking stringent measures, but as a legislator, maybe you can give us, what is our 90-day plan? What if we run out of alcohol and sanitizers, right?
Unfortunately, this is the biggest mistake that Kenyans do make, that legislators have any effect on the running of the government. This separation of power is the executive that runs the government. It's the White House up there, Uhuru and his team, that run the government. It's not the members of parliament. I'm not in this parliament, but that's also not to say that the members of the parliament who are there now have any authority or powers over what to regulate and what to not regulate in terms of the kind of things that the primary healthcare interventions that we need to do. But of course, the law is very clear. The subsidiary laws are basically like public health is always there. There are a number of ministries that do have those powers for them to do anything. They can quarantine, they can isolate, they can stop, they can lock down. I mean, that does not have to go back to parliament. It's the government agencies that are able to do that. It's the Ministry of Finance for purposes of taxation, Ministry of Health, Ministry of Livestock for control of livestock diseases. All those things do have those interventions, and you use the subsidiary or regulations, what you call. So they will have to work on that, and I think it's the government that needs to do that. And I don't know what the government has in store for Kenyans. We do watch every day Shikuku with, Mutahi Kagwe, the Minister for Health, who I think is doing a good job. He's very serious in what he's doing right now. But now, after exposure, I don't know why I should ask this question. What next? What do we do? For example, in your village, you have somebody who has that problem. Will you lock down that whole village? And if some of the villages have gone to also other neighboring villages, progressively you keep on locking down until you make sure that everybody affected. Because I'm told the main reason why the proliferation of new infection cases in Italy literally went over the roof, out of the roof, is because when a lockdown was announced in an affluent part of the town, people left and went to the other areas. Unbeknown to them is that many of them were carrying those viruses without any symptoms. So they went out there and spread it to the rest. So what do we do? When we see one case in a certain village, should we lock that village, lock down that village, and the next village, and the next village, and the next village, so that we try and control this epidemic, because there's no treatment for it, and we do not have the capacity that some of the developed countries who have reeled under that weight do have.
Maybe let me go first before Dr. Jibet. Let me appeal to those who are watching us now. Already, our health system is not doing well. That's the truth.
Without
COVID-19.
COVID-19.
Yes.
We're already on our knees.
We're already choked.
Yes.
Now, with COVID-19, again, so that we can help and we don't push our health infrastructure to the wall, we ought to assist so that this thing does not spread. Why? Reason being, this is a novel coronavirus, meaning it is new. We don't know much about it. One, it has affected the other countries that might not be in the same status that we are in. One, we have the highest HIV prevalence in Africa mostly. In Africa, the HIV prevalence is quite high. That's one. Two, it is not true that we don't have aged people. We do, and we know where they are. Three, nutritional status and comorbidities with other diseases, we already know what it is. So we need to make sure that this thing does not spread much. The only way this thing can stop is total lockdown. We ought not to lie about this. We better suffer for 2 weeks or 21 days than we better or we live to look or to make
Even if it's a month.
to make our country better after. But should we wait saying that we only have 25 cases, yet we have about 760 plus that are currently in a quarantine somewhere? We are joking with the worst disaster that we've never seen.
And the possibility that we probably even have thousands right now who are asymptomatic.
Yes.
And we're still within the incubation period.
True. Two, remember, this country, we've never had a pandemic in this country. Unlike Uganda, for example, that had Ebola at one time. So meaning their health workers, to some extent,
Are not prepared for such.
to some extent in Uganda, they were trained and they're well. Here, we took our health workers and went to Sierra Leone and Uganda to assist, and there are very few. They're being used now as a TOTs to train other health workers. That is not enough.
Trainers of trainers of train.
Trainers of trainers.
Yes.
That is not enough, because even as we speak, the number of health workers that we have in our health centers is not enough to take care of the Kenyans. And therefore, Kenyans must be very careful so that we don't get into this disaster. Should we, then the whole of the infrastructure, not only health, the whole of infrastructure, including everything and anything that touches on our health, because health is wealth. Should we joke with this, as we've been seeing so far? We are staring at the worst disaster that have ever happened in this country. Yeah.
Terrible epidemic. Dr.
Yeah.
Cases of course, exposure and interventions were done, basically to control. There's no treatment for it. And then they came out of it, tested negative. They went home and then tested positive later. What are the issues? What are the issues?
Yeah, so I think, frankly speaking, this is one disease that has scared everyone. I don't know if any one of us here has ever come into contact with a case.
I haven't seen any.
Personally had different exposures to different groups. Some have turned negative, and we thank God for that. Those that have turned positive, again, have possibly come into contact with some of my colleagues. And the disease is scary, trust you me. Secondly, if you look at the social structure in Italy, I don't think it differs so much from our structures here. We are social generally. We want to interact. We want to be happy with people. Italians are relatively good people. I've interacted with them quite a bit.
And families are very, very...
Yeah, pretty cohesive.
Very cohesive.
You can't disintegrate.
And big, in a sense.
Push them apart. And this is our structure here in Kenya. Secondly, if you were to talk about, lockdowns, they are not, again, very nice things to go through. But I keep saying sometimes painful things are better in life than excitements, that can be potentially be disastrous. I grew up in a village where cattle rustling was a big issue. And I remember the curfews were declared at certain points. And trust you me, life was never the same. So when I hear, total lockdowns, it brings a bit of jitters and some bit of scare within me.
But that's the only way we can survive.
But again, I think let's be real with ourselves. As Kenyans, we should be prepared with a total lockdown.
Yeah.
I think we've exposed ourselves too much to the extent that unless we took these extra steps, and I think we support the government fully in the steps that it is taking. But having said that, the moment a patient gets exposed, there are those that develop very basic symptoms. And the symptoms are not any different from the usual colds that we go through. You have someone who is having a dry cough, a bit of fever here, some generalized body weakness, headache may set in, you have a sore throat, sometimes you can have a cough. I mean, the normal, cold symptoms that we all encounter. And a lot of us will actually go through this phase. Those that get exposed will go through that phase. So we may even be having people out there who have already been exposed and going through this phase. But then we know that the government has been tracking
And
before.
they are very infective at that level.
Yes, so basically the disease, the incubation period ranges between 2 days and 14 days with a mean of about 5.2 days. And within the first 3 days, you see a spike of viremia, in the individual. Because when the virus gets into the body, the system is not aware. It's like being attacked without, being warned or forewarned. And so the virus takes advantage before the immunity sets in. And you have this surge of the virus within the body. And by the 3rd, 4th day, now the body starts to pick up.
The antibodies to start fighting.
Yes, the antibodies will then set in to try and counter the virus. And so by the 3rd, 4th day, the virus will start coming down as the immunity tries to step in. And so you'll see this symptomatology within the first, let me say the first 1 week. And a lot of patients within that particular time are highly infectious. So those that will show this symptomatology can easily pass the virus from one person to the other. So if you are to look at it from that perspective, then it simply means a lot of people can get infected within a very short period of time. By the time people are realizing that, oh, sorry, we didn't know you had coronavirus.
You have infected everybody around you.
Infected literally everybody. So that is one category. And actually, majority of the patients will have this kind of symptomatology. Over 80% will tend to show these kind of features. But then you have a certain cluster of patients who can then progress to the next level. And the next level is when the virus now starts to move further down into the lungs. And you have more than...
Pneumonia symptoms.
Yes, now pneumonia starts to set in.
Yes.
So the worst form of pneumonia...
Acute, respiratory system infection, which then clogs with the mucus and everything.
Yes. So basically the moment the virus now starts to settle down, goes further down, starts damaging the lung tissue, then you now start seeing people actually coming to hospital because either they are having difficulties in breathing, shortness of breath, basically they are unable to function normally. And we've seen a lot of...
Because there's no treatment for it.
What
are the kind of things that can be used to stop from the virus going down?
So basically, I think as we are discussing, the virus has no cure. The best we can do, and actually within the first phase of the disease progression, which tends to be milder in nature, you allow the body to self-defend itself. So the disease is supposed to be self-limiting. The body has to literally step in to protect itself. The moment it starts now sinking down and affecting the lung such that the lung is unable to function normally, then that is the moment at which you must be brought to hospital. Even if you had been quarantined before, now it is time for you to actually get to a treatment facility where you have to be supported. Remember, this virus has no specific treatment. But then you can get co-infections. You can get bacteria,
other opportunistic
infections can actually come on board. And so...
Because pneumonia is a bacterial infection.
Exactly. So basically what you want to try and do is to protect...
those other bacterial infections.
Yes, so you can actually cover the patient with, for bacterial infections. We now know that there are some antiviral agents that are being tried as well. But all this is under development. You've heard of
what about
chloroquine?
Chloroquine, which Donald Trump says is a treatment for this.
And take it from me, there's a lot of science behind chloroquine. So chloroquine is actually supposed to reduce the pH, again, trying to lower or interfere with the pH within which the virus operates. Chloroquine disorganizes that environment to the extent that then the virus is unable to replicate. And that is what chloroquine does. So there's a lot of science behind chloroquine. But again, the other challenge about the virus is that as the virus settles and sets its damage within the body, as the body reacts, it also produces cytokines or other substances that cause more damage to the body because of that level of inflammation. And actually that worsens the symptomatology more, and we see in adults, the disease becoming worse compared to the children. And these are some of the explanations that we have between the differences among us, either the children and the adults.
So the more your body starts fighting it, the more it becomes furious and it...
yeah, so for adults who have actually been exposed
you ignite the fury of... Yes.
You have some memory. And even when this virus sets in, the body actually is able to react in a bigger way than in a child because of the cellular and humoral response that the body tends to accord the virus. So basically, that again causes more damage to the tissues. And actually at that level, even if you are to be done an X-ray, for example, or a scan of the chest, you can see the level of damage to the lung tissue. And we use that to determine who gets what kind of treatment. Yes, so basically, like my colleagues
in Italy, they said that people who are older than 60, they leave them to die because...
I mean, because you see, you overwhelm, the facilities that are in existence. I think what he was talking mainly about on that point is that if you come to the facilities, right, the facilities now will have to do screening, right? Yeah. Who is really sick, right? Who can we save? Remember, we have only around 155 ICU
beds in the whole country.
And I don't know, 60% are already taken up right now. So
by other conditions.
Yes. So we are about to stretch that limit when we say, let's forget about what the government is talking about. Let's everyone go get infected. And if you look at my friend with his statistics, a lot of the people who are suffering the very severe form of the disease are coming up around the age of 40 and above, which is literally what I'm seeing on the TV, where people are moving, are still around this age, right? And they're giving it to older people. Now, as we manage hypertension, diabetic patients, we even have renal failure patients. These patients are on suppressive immunity drugs, right? The immunity is not normal. So this guy would be going around giving it to all of these people, right? So that's why we are saying, please, guys need to stay at home. We don't even have enough ventilators to support breathing as we speak. So these are the things we are thinking about, and we are saying we can't manage at this point if everyone gets sick. We have around 55 functional free ventilators. So we need to add the numbers. We have 50 million Kenyans.
We have how many?
Around 55 functional. So we need to start
ventilators
yes.
in the whole country.
So we need to improve.
Oh my God.
My friend, we also need to improve the people who are going to use these machines. You have to train people to use them. We need anesthetists. You have to measure.
So in the light of all those things, the only thing that we without any consideration for economy and everything else, all those other areas that we need to worry about is to put a total lockdown in the country so that nobody infects the other. Total lockdown. And then we begin now dealing with issues of how to put some little bit of money in the pockets of people, how to have food on the table, to deal with the nutrition, but at least save lives first.
We don't need to be shown videos of Spain and Italy, people sleeping on the floor because they don't have ventilators. Let's think about ourselves right now.
Tari, thank you very much. Unfortunately, we needed much more time than that, but we are running out of time, and until the next time we're going to get together, it's been a very, very informative, very educative, a learning process that we have gone through. And thank you very much. You're welcome. I can't shake your hands because of that. I can only say
thank you. Thank you.
Namaste.
Namaste. Viewers, we have come to the end of the show. Until next time, bye-bye.